السلام عليكم ورحمة الله وبركاته. How is everybody?
وعليكم السلام يا دكتور.
Can you hear me? Okay.
Yes.
طيب يعني I have two attendees now. يعني is somebody else coming ولا إيه؟ This will count out of the 40 minutes. Can somebody please write on the WhatsApp group?
I already did.
Okay, thank you. Can you please tell me if you can see my screen?
يا دكتور.
Yes, doctor, is clear.
Okay. Okay. Is it small or in slideshow?
No, it's small.
Small.
It's small. Okay, let me check. Check first.
دكتور في ناس waiting على hold.
Yes, I admitted them. This is why I don't want anybody to be late, because once I start, I won't be able to admit anybody. Okay. Okay, how about now? Is it slideshow?
Yes, doctor.
Is it moving or is it fixed?
It's moving.
No, it's
Great. Okay. All right. Somebody else coming? Yeah, I have only 12 participants out of how many? 35. Hmm. Okay. So I will start anyway, because you know that Zoom will cut off after 40 minutes. Okay, so this counts out of the 40 minutes. And we have already lost how many minutes? Let me check. 3 minutes, okay? So I will start my session. So once again, just a quick reminder, please keep your microphones and video cameras mute at all times, because I want to lessen the background noises, the echoes, and I want to improve certainly the internet connectivity. All right. And if there is something yet that you don't understand, or if I'm going too fast or too slow, please tell me. All right. So the revision session, I promised you to hold 2 revision sessions. I'm going to organize them in an anatomical way, starting from the pituitary down. All right. So the slides are stuck. 1 minute. The intended learning outcomes of today's revision session are as follows. By the end of today's session, you're going to be able to understand the anatomy and physiology of the hypothalamic pituitary axis, very important. You are going to be able to list the symptoms and signs of hypopituitarism, equally important. And you're going to be able to list the signs and symptoms of acromegaly and understand the various imaging modalities in hypothalamic and pituitary diseases, right? So starting by the anatomy of the pituitary gland, as you all know, can you see my cursor, or shall I put it as a laser pointer better? Can you see my cursor now?
Yes, doctor.
All right, great. So the pituitary gland is a very small structure measuring millimeters, right? Inside a bony cavity inside the sphenoid bone called the sella turcica. And mind you, the size of the pituitary gland may double during pregnancy. And this has very important repercussions on a disease like Sheehan's syndrome. Okay, so this is the anatomy that we see in the anatomy textbooks. The same exact anatomy we can see inside the living body of a person or a patient, okay, by doing MRI, magnetic resonance imaging of the pituitary gland. This is a sagittal cut like that. If you can see my picture, it's cut along the sagittal suture. All right, so let me revise the anatomy. In MRI, what is black is either air or flowing blood, and what is white is bone. And the gray things, structures that appear, are the soft tissue structures in between. So let me revise the anatomy. This is the nose, and these are the turbinates. This is the tongue, the epiglottis, and this is air in the oropharynx, air in the trachea, and this is air inside the sphenoidal sinus. And inside the sella turcica, you can see a white and gray and white structure, which is the pituitary gland. Okay, the anterior pituitary gland appears somewhat grayish in color. This is without contrast, by the way. While the posterior pituitary appears as a bright spot, it appears very white in color due to its high content of antidiuretic hormone. And above it is the pituitary stalk, this tiny structure connecting the anterior pituitary to the hypothalamus, and above the pituitary is the optic chiasm. And of course, this is the corpus callosum, this is the cerebellum, and this is the midbrain, pons, the medulla oblongata, and these are the cerebral hemispheres with the gyri and the sulci. All right, until here, any problems? Am I going too fast?
No, doctor, it's clear.
Doctor,
All right. Okay, fine. By the way, imaging is important not only for the exam, but also for your careers as physicians. All right. Imagine you're sitting at home, and one of your neighbors rings the bell. Please, doctor, can you tell me what is in this MRI? Or can you tell me what is in this CT? You will tell him or her, bring me the report, I will read it. Unfortunately, I have lost the report. So what will you do? Will you tell your neighbor, I'm not able to read an MRI or a CT? Okay, imagine this situation. I tend to over-dramatize in order to make things very clear why it is important to know the imaging. All right, so let me continue. Like we have a sagittal cut, like that. This was the sagittal cut I just showed you, all right? We have also a coronal cut like that along the coronal suture. So let me revise the anatomy. The same applies. Air appears black. So this is air in the oropharynx. This is air in the sphenoidal sinus. And here you can see on either side of the pituitary gland, in the cavernous sinus, we have two black structures, which are the carotid arteries. And like Dr. Ahmed Alek showed you in one of the scientific meetings very nicely, why does it appear as two apertures? Because there is the carotid siphon, so it is cut like that in coronal cut. So we have two apertures. And why is flowing arterial blood signal void, or it appears black? Because the blood is constantly flowing. Okay, so there is not enough time for the hydrogen ions to be taken up by the magnet of the MRI and then released to release the energy that is taken up or captured by the camera. All right. Let me check inside the cavernous sinus on either side. This is the right side. This is the left side. We have, in addition to the carotid artery, we have also several cranial nerves, like the oculomotor or third cranial nerve, the trochlear, or the fourth cranial nerve, and the upper two divisions of the trigeminal nerve, namely the ophthalmic and the maxillary divisions. And we have finally the abducent nerve, or the sixth cranial nerve. This also has very important repercussions on pituitary tumors, because, like I'm going to show you, some macroadenomas, some very large pituitary tumors that are more than 1 centimeter in size, they can either extend supracellular, above, encroaching on the pituitary chiasma, or laterally, paracellular, either into the right cavernous sinus or into the left cavernous sinus, encroaching on the structures inside, which are the carotid artery, can encase it, but also the cranial nerves, the oculomotor, the ophthalmic, and the trochlear and abducent nerves. And I will tell you later on when we discuss acromegaly together. I've seen once a case. She was a female patient. She was in her 40s, or maybe in her 20s. I don't remember exactly. But she came complaining of squint in one eye, squint, in addition to headache, all right? And she had also numbness in the forehead and in the cheek of one side. And when we did the MRI, it turns out that she had a a very large macroadenoma in the pituitary, of course, growth hormone secreting adenoma, which caused acromegaly. In addition to that, it encroached on the carotid artery, encasing it, and on the abducent nerve, and on the upper two divisions of the trigeminal nerve. All right. So, any problems so far?
No
No,
problem.
doctor.
All right,
No problem.
great. Now let me revise hypopituitarism. 1 minute. Yes, as you can see, the consequences of hypopituitarism are multiple, because the pituitary gland is considered to be the maestro of all other endocrine glands. So, of course, if we have growth hormone deficiency in children, it can cause short stature. In adults, until recently, it was said that it didn't have any effects, but it was found to cause chronic ill health and impaired well-being in adults. And the effect of hypopituitarism on gonadotrophins causes infertility in males and in ladies, okay? In males, it tends also to cause a reduced sperm count, while in ladies, it can cause also hypogonadism, leading to menstrual irregularities and even amenorrhea, all right? And TSH deficiency will cause secondary hypothyroidism, while ACTH deficiency can cause secondary hypoadrenalism with loss of pigmentation, with all the other manifestations of hypoadrenalism, right? And of course, antidiuretic hormone, which is released from the posterior pituitary, if it is deficient, it can cause diabetes insipidus, right? But actually, many textbooks consider hypopituitarism only affecting the anterior pituitary, right? But in some conditions, like in craniopharyngioma, for example, which is, we will discuss later on, it's a tumor arising from Rathke's pouch above the level of the pituitary, and it can encroach down on the pituitary gland and stalk in particular. So it can cause, in addition to anterior pituitary hypofunction, it can also cause diabetes insipidus, right? Now, the clinical features in hypopituitarism, they differ according to gender. In women, as I mentioned, it tends to present with amenorrhea, infertility, vaginal atrophy, dyspareunia, atrophic breasts, loss of axillary and pubic hair, right? Dyspareunia means what? Who can tell me? What is dyspareunia?
It's painful sexual intercourse.
Yes, very good. Excellent. And in men, of course, it causes hypopituitarism causes loss of libido or impotence, infertility with soft atrophic testes and loss of secondary sexual characteristics. And in both men and women, TSH deficiency will cause mild to moderate hypothyroidism, secondary, of course, and ACTH deficiency leads to weakness, postural hypotension, pallor, and hypoglycemia, and all the other manifestations of secondary hypoadrenalism, right? Now, the clinical features of hypopituitarism, they depend on the extent of hypothalamic and or pituitary deficiencies. Of course, secondary hypothyroidism and adrenal failure both lead to tiredness and general fatigue. So you cannot distinguish them, right? While hypothyroidism causes weight gain, slowness of thought and action, dry skin, and cold intolerance. You all know that, right? In hypopituitarism, particularly that caused by stalk effect. With stalk effect, I mean cutting of the pituitary stalk by trauma, by surgery, by a tumor enlarging supracellularly, okay? Or by destruction of the area of the pituitary stalk by an expanding macroadenoma. This will cause hyperprolactinemia, right? And it may cause galactorrhea with secondary hypogonadism. Why does it cause hyperprolactinemia and not hypoprolactinemia? Who can tell me? Very easy. Who can tell me? Can you still hear me?
It's due to, yes, doctor.
Okay,
It's
okay.
due to the loss of the suppressive effect of dopamine on the
Yes.
on the
Or prolactin.
lactotropes.
Yeah, exactly. Very good. Excellent. Excellent. Okay, so remember, in hypopituitarism caused by stalk effect, okay, hyperprolactinemia occurs and not hypoprolactinemia. And as I mentioned, growth hormone deficiency causes growth failure in children and impaired well-being in some adults, right? The weight, as I mentioned, it may increase due to secondary hypothyroidism. But in cases of severe combined deficiency, what we call pituitary cachexia, the patient may lose weight and excessively and is excessively thin, like skin over bone. I will show you pictures of some patients later on. Okay? And in long-standing pan-hypopituitarism, this term pan-hypopituitarism means deficiency of multiple anterior pituitary hormones. It gives the classic picture of pallor with hairlessness, what we call alabaster skin, of course, in men, because they have the males have a hairy body. Okay, this is galactorrhea, and mind you, galactorrhea means, by definition, it means milk secretion from a non-lactating breast, non-lactating. Okay, and it can be spontaneous, like you see in the picture. The patient will come complaining of that. There is milk coming out of my nipples. I'm not lactating, okay? Or it can be expressible. What does it mean, expressible? You ask the patient, do you have milk secretion from the nipples? She tells you no. But when you examine the patient, you need to squeeze the nipples from side to side. If milk comes out, this is expressible galactorrhea. A very important sign not to be missed, okay? And this is how pituitary cachexia looks like. Imagine, this is a lady, you see, but she looks almost like a child, and she looks skin over bone, like the starved patients in the various famines in Africa, you see. And this is the picture of the patient when she was healthy, and this is the picture of the same patient after she developed pituitary cachexia. You see, the breasts became atrophic. There are no muscles, complete wasting, okay? And this is another picture, you see, skin over bone. And here is the lady before when she was healthy, and here after she developed pituitary cachexia, okay? Is it clear? I wanted also to ask you about 3 different terms that we need to differentiate. What does wasting mean? What does emaciation mean? And what does cachexia mean? Who can tell me? Is there any difference, or are the 3 terms equivalent? Who can tell me? Can somebody tell me? I don't see you actually. I need to open. I don't see any raised hands.
دكتور I can't remember the exact definitions بس أنا فاكرة إن كان في حد فيهم loss of subcutaneous tissue وكان في واحدة فيهم loss of muscle mass بس I can't remember which is which صراحة.
طيب, who can remember? طيب, you're almost there. You're almost there. Who can tell me? Who can tell me? Who can add to
Cachexia,
what
loss
Dr.
of
Menna said? Sorry? Yes, tell me.
cachexia, you mean loss of fat
Cachexia is
subcutaneous
what?
tissue
Now, say again, please, because the voice is interrupted. I cannot hear properly. Cachexia is what?
loss of fat, subcutaneous tissue, muscles.
Cachexia is loss of fat and muscles, right? Okay.
Subcutaneous tissue and subcutaneous tissue.
Okay. And then what? What else?
I think it, doctor, I think
Wasting.
protein loss.
Sorry?
I think cachexic protein loss, emaciation fat loss.
No, you said cachexia is loss of both muscle and protein, right? It was you, Dr. Awan Ragab, right? Who answered earlier.
Right, doctor.
Okay, type. What is wasting and what is emaciation?
Emaciation fat loss, I think.
Yes, yes. And wasting is protein loss. Very good. Thank you, Dr. Arawan and Dr. Amenna. Okay, very good. Can you still see my presentation?
Yes, doctor, but it's not in the yes. Now it's okay.
Okay, fine. So let's continue. Remember when I told you about alabaster skin? This is an adult male, all right? He's complaining of feeling cold all the time. He is lethargic. He feels dizzy on standing, and he is weak, and he has constipation. These are his complaints or the symptoms. Now, when you started examining the patient, you noticed pallor. This pallor is not only present in the mucous membrane, but in the skin all over the body, like you see here, okay? And if you notice closely around the mouth, here the eyes are covered, of course, for privacy, but around the mouth, the patient has some wrinkles, okay? He looks like an old man. And he has also loss of secondary sexual characters, no pubic hair, no body hair, no facial hair, okay? And so a pale skin without hair, we call alabaster skin. Why alabaster? What is alabaster? This is alabaster, remember? It's the type of stone that we have here in Egypt. It's very common. The ancient Egyptians, they used to use this type of stone to conserve the internal organs of the mummies when they mummified the pharaohs, right? In canopy jars. You can see them in the Egyptian museum if you go. And nowadays, even the gift shops around the touristic attractions in Egypt, they tend to sell some alabaster items, right? So they look like that. They are very smooth, and they look orange yellow in color. Exactly like this patient's skin. So hence the name alabaster skin. I hope it is clear now. Okay? Now, we have a very important entity that causes hypopituitarism. It can cause, because not all cases of empty cell syndrome have hormonal deficiencies. What is the empty cell syndrome? Remember when I mentioned the MRI of the pituitary gland early on in my presentation, I showed you the sagittal section of the MRI, okay, and the coronal. Now let's look at the sagittal section. It's cut like that. Here is the sphenoidal ear sinus. The white cavity here is the sella turcica, bony cavity. Type, look inside. Where is the pituitary? Here you can see the pituitary stalk almost reaching till the floor of the sella turcica. So here the pituitary gland appears to have vanished, or the sella turcica appears to be empty. Hence the name empty sella syndrome. Now let's look at the coronal section. Coronal is cut like that again. Here is the bony sella turcica. Bone appears white. Okay, this is the pituitary stalk. It's very nice and centrally placed. And here's the optic chiasma. Top. Where is the pituitary tissue? It should appear gray in color, right? It appears as if it's empty. So hence the name empty sella syndrome. Is it clear? Any problem so far?
No, doctor, it's clear.
Okay. And of course, you know the cause. It can be either due to a congenital deficiency in the aperture of the diaphragma celli, which accommodates the pituitary stalk. Okay, if it's too wide, some CSF from the supracellular cistern that's located around here, okay, can trickle down the sella turcica and compress the pituitary gland against the floor or the posterior wall or the anterior wall, depending on how the dynamics of the compression go. All right, or it can occur due to following presence of a pituitary tumor that has shrunken. Okay, anything that shrinks in the body has to be replaced either by fibrous tissue or in the sella turcica here, in this case by CSF. Okay, so this is how empty sella turcica occurs. Any problem so far? Now let's shift to acromegaly. Of course, you all know the clinical features of acromegaly. They are symptoms, the patient's complaints. The patient, he or she, will complain of change in appearance. Of course, you know that female patients or ladies, they notice any change in the external appearance more than men do, right? So they come running. Increased size of the hands and feet, headache, excessive sweating. This is very irritating, particularly for ladies. She would come tell you, I take like 5 showers a day and still my skin feels very sweaty and oily. All right. Visual deterioration, tiredness, weight gain, amenorrhea or oligomenorrhea in women, galactorrhea also in women, right? Impotence or poor libido in men. Deep voice. It's normal for a male to have a deep voice, but it's not normal for a female to have a deep voice. Why do you think the voice deepens in acromegaly? Who can tell me? Who can tell me?
laryngeal growth, vocal cord growth.
Exactly, both of them actually. You know, whoever is into music, you know that an orchestra has several string instruments. The violin, it's soprano, okay, and then the viola, the sound has a deeper pitch, and then the violoncello, and then the deepest pitch is the contrabass because it has the biggest resonance box. The same applies to the voice box or the laryngeal box, all right? And like you mentioned, also thickening of the vocal cords can cause change of voice. I mean, the pitch of the voice, okay? It tells me here that we have 10 minutes left in the meeting. So whenever the meeting cuts off, please join via the same link that I have sent you on the WhatsApp group. All right. Now let's continue.
Okay.
Goiter. Why does goiter occur in acromegaly? Who can tell me? Why does
The effect of growth hormone on the thyroid tissue.
Yes, growth hormone actually causes growth of all bone and soft tissue in the body. And the soft tissue includes also the thyroid gland, right? Very good. Excellent. Breathlessness, pain and tingling in the hands. Why do you think an acromegalic patient would present with pain and tingling in the hands? Who can tell? Yes, excellent. Due to compression of the median nerve under under the flexor retinaculum because the posterior aspect of the carpal tunnel is made by the carpal bones, and the lateral aspects and the anterior aspect are made by soft tissue, the thenar, the hypothenar, the thenar and hypothenar muscles, and the flexor retinaculum. All of these, when they enlarge, they compress the median nerve in the carpal tunnel. Very good, excellent. Polyuria and polydipsia, why do you think?
Diabetes insipidus.
No, because growth hormone is an anti-insulin hormone, so it can cause secondary diabetes mellitus. Okay? All right? And muscular weakness. The muscle weakness in acromegaly, not only in acromegaly, this type of muscle weakness is present in most of the endocrine diseases that we have studied all through the semester, in hypothyroidism, in hyperthyroidism, in hyperparathyroidism, in Cushing's syndrome, as well as in acromegaly. And in okay, so to such an extent that it's proximal in nature, proximal affecting the shoulder and pelvic girdle muscles. Okay, so how will the patient complain? I mean, the patient will not tell you I have weakness in my shoulder or in my pelvic girdle muscles, but how will the patient complain? What will he or she tell you? Who can tell me? Huh?
She cannot climb the stairs, for example.
Yes, yes, very good. What else?
She cannot comb her hair.
Yes, yes. What else?
Can stand from a sitting position without
Yes.
support.
Yes, excellent, excellent. And in that context also, if she cannot stand, or he, I mean, if they cannot stand from a sitting position, they can also not rise from a stooping position. I remember one acromegalic patient we have seen at our endocrine unit. She came complaining she had, this Arabic toilet on the floor, Hammam Arabi. She couldn't stoop over it. So she asked her husband to change it and bring her a regular toilet like all of us use. It's like a stool, right? But even though she couldn't rise from this sitting position, right? And in addition, she used to sit on the floor cross-legged like that, okay, on a pillow, but she couldn't do that any longer because she couldn't rise from this sitting position on the floor, right? Now, in the lower limbs, like you mentioned, she can't climb the stairs, but here you have to be very particular. You have to ask her, why can't you climb the stairs? She may tell you because of shortness of breath. This is not due to muscle weakness, of course, okay? But if she tells you because my legs feel heavy, they don't support me, or I cannot, they feel like bags of sand, this is muscle weakness, all right? But some patients, they may tell you because I have pain in the legs. You need to analyze this pain, and when you start analyzing the pain, you will find it to be muscle weakness rather than pain. This is very important. All right. And in the upper limbs, like you mentioned, she cannot comb her hair like that. The same acromegalic patient I told you about, she had long hair and she couldn't comb it herself. So one of her daughters used to do that for her, and then she decided to cut her hair short à la garçon like that in order to be able to comb her hair herself. In addition, in the countryside or in some rural areas, female patients, they tend to wear a headscarf and they cannot tie a knot. They cannot do this maneuver, okay? And if she's standing in the kitchen, she wants to bring something, to put something on a shelf high above the level of her head, or bring something from this shelf down, she cannot do this maneuver because of weakness in the shoulder girdle muscles. Or she will also tell you pain, and when you analyze the pain, you will discover it is muscle weakness rather than pain, all right? And joint pains, of course, joint pains occur due to secondary osteoarthritis, right? You see, in acromegaly, there is enlargement of the joint cartilage, enlargement of the bones. So the joint mechanics, they are disturbed. I remember I saw a male patient, a young 32-year-old male patient who had all the classic features of acromegaly, including impotence, decreased visual acuity, and he used to wear very thick eyeglasses like that, Kabakubeya. Okay, and he had the typical features, the facial features, the coarse facial features, enlarged hands and feet, and he had also impotence, but he was not married, so he was embarrassed to talk about it. Oh, so what bothered him a lot was joint pains. So where did he go? He consulted our colleagues at the physical therapy department for bilateral knee pain and clicking. Okay, so of course it was a spot diagnosis. They diagnosed him at once. You have acromegaly, and this is what caused your joint problems. So they sent him back to us. All right. And remember, old photographs, like I'm going to show you after a while, are frequently very useful to diagnose acromegaly, because actually it is a very insidious or gradually occurring disease. Okay, and mind you, symptoms of hypopituitarism may also be present in addition to the symptoms of acromegaly. Why? Because if the acromegaly is usually caused by a growth hormone secreting macroadenoma. If it is large in size, in addition to growth hormone with or without prolactin hypersecretion, okay, there will be compression on the other pituitary cells secreting the other pituitary hormones, and this can lead, in addition to hypopituitarism concerning the other pituitary cells. Any problem so far?
No.
Okay. Nobody asked me why amenorrhea and oligomenorrhea occurs in acromegaly in women and galactorrhea and impotence or poor libido in men. Who can tell me why?
Hyperprolactinemia.
Yes, why does hyperprolactinemia occur in acromegaly?
ممكن الأدينوما عاملة ستوك إفكت.
Yes, this is one cause, but the more important cause is that many of these growth hormone secreting adenomas are pluripotent. Pluripotent means they secrete more than one hormone. So they secrete growth hormone in addition to prolactin. All right? Excellent. Now let's look at the signs. We as physicians, when we examine an acromegalic patient, we will notice the following: prominent supraorbital ridges. This is okay in men, but it's not normal in women, right? Prognathism. In order to examine for prognathism, you have to tell the patient, please show me your teeth. Because often in the OSCE station, you say prognathism without having done the proper maneuver. What is the proper maneuver to do that? If you can see my picture, you ask the patient, show me your teeth, like that. Okay, so you will notice that normally in all of us, the upper incisors, they are in front of the lower incisors. But in case there is prognathism or protrusion of the lower jaw, the reverse occurs. The lower incisors, they come to lie in front of the upper incisors. And some patients even complain about that. They complain not only about the cosmetic appearance of their teeth, but we had one patient who used to complain, I cannot bite a sandwich. So I used to cut off a bite and eat it because the malocclusion, right? Interdental separation. All of us, the teeth, they are close together. But when the bones of the maxilla and the mandible widen, the teeth, they start separating. Okay? This is also not cosmetically appealing for many women.